My name is Dawnette Lewis, and I'm a high-risk pregnancy specialist at Northwell Health at one of their birthing hospitals, North Shore University Hospital. I'm the director for maternal fetal medicine. About a year ago, our CEO, Mr. Dowling, recognizing that disparities do exist, launched the Center for Maternal Health with the aim of decreasing some of the disparities that we see for our Black birthing patients. And under the Center for Maternal Health, we work with community and population health to work with the community and CBOs to engage patients and to get the message out, and to also use community and population health for education. It also comprises of the OBGYN service line where I reside. And you talk about policies and physicians. That's where we develop policies around Pitocin, about postpartum hemorrhage, in order to improve outcomes for our patients. So we got a small grant where patients who are considered at higher risk, for those patients to be navigated by nurse practitioners and nurses after they were discharged from the hospital. And we found that with that navigation program that we were able to decrease the 30-day readmission rate for severe maternal morbidity by about 50%.
Wow.
For all our birthing patients.
Wow.
And we were able to decrease that rate by about 60% for our Black birthing patients. Wow. With the Birth Equity Improvement Project launch, one of the slides talked about how Black birthing patients said, we feel like we're always being sectioned. And I thought about myself and I said, that's not true. And so when we looked at the data in our four walls, it was true because we saw that the primary nilipristorm singleton vertex cesarean delivery was 37% for our Black birthing patients compared to 24% for our white patients. So it challenged us to see what can we change and what can we do differently in order to decrease that nilipristorm singleton vertex delivery rate. So when we talk about technology, AI, and data, it's important to find out that, to know that even at home, where we think that everyone has what they need, that capability is not there in a lot of these communities. We see patients, they're already sick. So the things that we are interested in is moving all that work upstream and identify patients preconceptionally and in the prenatal, early antepartum period, identifying patients who are most at risk in order that we can mitigate some of those risks during the pregnancy. We know that we can't completely eradicate those risks, but if we can get patients as healthy as possible, I think that's where a lot of that work needs to be done. It needs to be done preconceptionally, and it needs to be done in the early antepartum period. The fourth trimester is very important, like you mentioned, Marianne, because about 80% of the deaths that occur in that postpartum period. So we still need, like the wonderful work that you're doing, Marta, in the postpartum period, we still need a lot of help in that space. And I know in another panel, behavioral health was mentioned, and we know that we don't have the workforce available to provide the behavioral health that is needed in maternal care and just in general healthcare in the United States. So if we can, have companies that are really vested in helping moms with behavioral health, I think that's very, very important. I'm just excited that this conversation is being had and that Northwell Health is there as a part of the solution. And I'm excited about our Moms Navigation Program and hopefully scaling it to our entire health system to cover all 30,000 women that deliver in our healthcare system.
All right, well, please join me in thanking these badass women who are doing it every day.
Yay.